All right, everyone's ready. I was just giving it a few minutes to have our participants join us, but I'll start with the introduction of our live webinar today. I'd like to thank all of you for joining us today, signing up and joining us today this is part 3 of our series, where we've been looking at the intersection between antimicrobial stewardship and diagnostic stewardship and how that's impactful and how we put it into practice. What we've done with this third part of the series is we've invited back all of our speakers from part 1 and part 2. And we're so lucky that they were all able to attend today. The title of the webinar is Lessons Learned and Looking to the Future of Diagnostic Testings, the Experts Return. As you can see there, we've got our expert panel listed. Dr. Brandon Bookstaver from the University of South Carolina, Dr. Robin Patel from Mayo Clinic, Katherine Perez from Houston Medical Center, Dr. Ferric Fang, University of Washington School of Medicine, and we're very excited today to have Dr. Debbie Goff, professor at the Ohio State University. She'll be the moderator today. So I'm the host, Dr. Marty Peterson, but Dr. Goff will be our moderator. And this has been a collaborative effort between the Center for Infectious Disease Research and Policy and the Society of Infectious Diseases Pharmacists. So very excited to have you all here today. Before we begin our conversation, a couple things to note. We are offering CE, so as part of this being a CE educational activity, we've got some slides around the disclosure. So ProCE is our CE provider, and we've got listed there of all of our speakers today, our moderator, the host, and all those involved in the development of this program, relevant conflicts of interest. So showing you those there today. The other component of this is an educational activity. There may be some conversation around discussion of published or investigational uses of agents that are not indicated by FDA. Of course, keep that in mind that this activity is not to recommend the use of any agent outside its label's indications, and as an educational activity, these are our expert opinions. And the participants have implied responsibility to use the newly acquired information to enhance patient outcomes in their own professional development. So you, as the participants of this activity, all of our listeners, understand this is educational and it's specially designed to enhance your ability to enhance your clinical practice or your professional development. All right, so our target audience: physicians, pharmacists, nurses, and clinical laboratory personnel. So wide range, and the conversation, that's why we have these experts, pharmacists and physicians that practice in these different settings. The discussion will be around 3 main learning objectives. We first are going to talk about the impactful ways that the integration of rapid diagnostics in antimicrobial stewardship programs can impact patient outcomes. We'll also then specifically dive into Clostridioides difficile testing modalities in practice, some of the strategies to effectively use diagnostics and then implement your stewardship programs in that disease state. And then finally, we look to new technologies. We'll be discussing when do you incorporate next generation sequencing technologies or other like sequencing technologies into your clinical decision making. What are these experts using right now in clinical practice, and how are they using those tools? And finally, our funding, we'd like to thank bioMerieux for the educational grant support for this 3-part series. So thank you to them for understanding that this is important information to bring to all of you and your contact time with these experts. This is all the CE that we're providing. We've got pharmacist CE, CME, BCIDP, also recertification credits. So you'll want to, if you're listening for these purposes and getting the content, you'll want to visit bpsweb.org to receive recertification by continuing education. We also have nursing continuing education and ASCLS PACE program for clinical laboratory professionals. So really, really a CE rich experience today. Finally, how do I get my CE? You'll go to www.proce.com. You'll take a post-test, an evaluation, and your deadline for the live portion of this is June 4th. The code is provided at the end, and I will do that. I will do so. Finally, to all the participants listening, before I hand it over to Dr. Goff, we want to hear from you as well. There's a chat box. If you're on Zoom, please submit your questions to the moderator, to myself, and we will get into that with our speakers towards the end of this webinar. And the last thing I didn't mention is this webinar is actually for 1 hour and 15 minutes, so you'll get 1.25 hours of CE credits. So stay on if you can past the hour time point. And with that, I'm going to turn it over to Dr. Goff as our moderator today.
Thank you, Marnie. It is a pleasure to be moderating this discussion. It's one of my favorite topics, the integration of rapid diagnostic tests with antibiotic stewardship, lessons learned, lessons that are going to come forward in the future, and really to work with such an expert panel. I've had the pleasure of working with almost all of them in the past, so I know we're really in for a great discussion because they bring years of expertise to this discussion. So let's get started. When we look at integrating rapid diagnostics into antibiotic stewardship, Dr. Fang, you started in your presentation really demonstrating that importance of going through several studies that were published where stewardship with rapid diagnostics and microbiology's input really holds the key to using the rapid blood test that we use so frequently in stewardship. So can you really tell us why this is so impactful and how you make that happen at your own institution, that collaboration between the two?
Certainly, I'd be happy to. I think there are a number of advantages by having a really closely integrated microbiology, clinical pharmacy, and infectious disease consult team working together for stewardship aims. And clearly one of the benefits is the time to take a rapid result and translate it into an actual change in a patient's treatment regimen. One of the things that I reviewed in the earlier webinar was a meta-analysis by Tristan Timbrook, which showed that integrated programs where stewardship was coupled to rapid diagnostics had better clinical outcomes. And one of the things that came out of that study also is that the primary benefit was seen in patients with gram-negative bloodstream infections. And the reason for the advantage in gram-negatives is that you're most likely to have multi-resistant pathogens or pathogens that are not covered by empirical regimens, so-called discordant therapy. And people have shown recently a large study of over 130 hospitals in the US that was in Lancet Infectious Diseases, showed the importance of discordant therapy in terms of predicting mortality. And discordant therapy is highly associated with resistance. So all of these things mean in those patients who have gram-negative bloodstream infections with resistance, it's very important to immediately escalate therapy and adjust it to accommodate that. So that's clearly one of the important advantages. A second thing, though, I would say from our experience is the personal connection. Our clinical pharmacists are always on the wards. They know the clinicians really well. In contrast, not all of the primary services spend a lot of time face-to-face in the clinical lab. Even though we're in the hospital, we try to reach out to them, but we end up occupying different spheres. So to get advice from people that they see every day, that they trust, that they are used to going to for clinical information, just makes it seamless, I think, for some of these primary services to take that advice. And so that connection is important. And also, of course, the pharmacists have specialized knowledge, so they feel much more confident about making recommendations. I think some of the newer house staff may see the presence of a resistance determinant that we detect in the clinical lab, and they're not exactly sure what to do with it. And so the tendency is to wait until next morning's rounds to discuss it with more senior people. But if the pharmacist is there and says, this is taking this result into account with the normal susceptibility patterns at our hospital, I would recommend switching the patient to this therapy. It makes it much easier for the clinicians to make those decisions in confidence. And I know that Robin Patel did this beautiful randomized clinical trial of rapid diagnostics that everybody talks about with root of energy. And one of the things that came out of that is that clinicians were reluctant to de-escalate without some kind of guidance from stewardship, whereas escalation was a little bit easier for them to do on the basis of the result alone. So I think if we believe in de-escalating as an important way of removing unnecessary therapy to help the patient with resistance, then having this kind of personal relationship between stewardship and the laboratory and the clinicians is really vital. And I would finally say there was actually a study in open forum infectious disease where if you can do real-time stewardship and not limit it to 5 days a week business hours, but you can actually deliver that kind of consultation all the time if your staffing permits, it looks like the clinical outcomes are better, which one would predict, but it's actually been shown.
You brought up so many great points, but the one that just really resonates is how they have to know and trust the steward. And I think that is such a key component. People tend to think they can do stewardship sitting behind a computer and just call. But if they don't know you, they don't trust you. And, Katherine, I'm going to turn to you because I remember when you were a PGY2 resident and you published one of the very first papers on using rapid diagnostic test with a pharmacist intervention. And it was just a brilliant paper. And I do remember because you were a PGY2, you took that phone call 24/7. So I know you have personal experience giving that around the clock stewardship with the micro lab. Tell us a little bit, that was several years ago at this point in time now, but obviously you learned very quickly the value of a rapid diagnostic test with stewardship, but you moved on to another place. So tell us kind of your journey of how you learned that as a resident, and then how did you translate into your practice now?
So I'm actually still at Houston Methodist. So I've continued in my role. As a PGY2, I essentially was able to demonstrate the value of having that around the clock notification. And a lot of times that can sound very daunting. And I think it's really important to make sure you focus on what your laboratory is also capable of, because if your laboratory is not, resulting or verifying susceptibilities in the middle of the night, then that makes the stewardship stuff a lot easier, because then, it's not 24/7. So I think that that's really important to note. I think that it's been a really fantastic journey over the last, I think it's almost been 10 years now. And we've implemented multiple rapid diagnostics, really using the same template. We've, used this same approach where we call the clinician only when it's necessary, and they try and affect that patient's immediate disposition. And I think that that's really where we were able to establish a lot of buy-in and a lot of rapport with our clinicians, because they know that when they see, that page come across, that it's not going to be something silly or, from their perspective, something silly like stopping a drug that isn't even scheduled to be given until the next morning or something like that. And so those are small things that the stewardship team can work together on beforehand to try to train and mitigate those conversations so that we can have those successful interactions, because they are so important to our patients.
Thank you. Robin, tell us a little bit about your experience when you published the study and the de-escalation, some of the challenges you observed, and how you've moved that forward now.
Absolutely. We learned so much from doing that study. This was a rapid multiplex PCR test done on positive blood culture bottles. And we had 3 arms in the study. One our standard of care, and then the other 2 arms were both a rapid diagnostic, but one of them had stewardship added on top of the rapid diagnostic. And as Ferric mentioned, people we're not comfortable de-escalating just getting that result from the clinical microbiology laboratory. They really needed that stewardship guidance to de-escalate. Escalation, if you told someone there was MRSA in the blood, they kind of knew what to do. But I think that too can become more complicated as we have more nuanced microbiology reports. So we have to be careful about that there can be a lot of value there as well. And we know that escalation is very important for patient safety, right? De-escalation is it's around patient safety, but also around antimicrobial resistance and microbiome disturbances and cost of care and so forth. And so having learned that, we've subsequently executed and published another study looking at the value of rapid diagnostics. And we're in process of executing a third one. And we just incorporate stewardship, antimicrobial stewardship into all of our arms, even our control arm, because I don't think it's fair today to ask a scientific question about whether a test works or not without involving antimicrobial stewardship. It's just so important.
I agree. And that's such a great point to make. And I think in talking about de-escalation, it is one of the harder things to do in stewardship. And it's a great segue to the question I'm going to ask you, Brandon. So knowing when to de-escalate antimicrobial therapy in the critically ill patients in the ICU, how do you actually use rapid diagnostics and genotyping with a traditional in vitro model?
Thanks, Debbie. Yeah, this it's certainly not straightforward because we know our critically ill patients have a much smaller margin of error and certainly utilize broader spectrum, most of the time, broader spectrum, multiple antibiotics empirically as compared to maybe other folks with lower acuity. One thing to preface this, our hospital, Prisma Health, we, to piggyback on some things that were said that does set the stage for how we do this in an ICU, the rapport and the interactions there are very strong. We always talk about our culture of de-escalation, or our culture of stewardship is very active in our ICUs. So while we have a 661 bed teaching hospital with 3 other community hospitals around, our steward extenders are very active in the ICUs. So by the time we get to an action item, often it's already been taken care of, which is great. One of our full-time pharmacists in stewardship was a critical care pharmacist before merging into stewardship, and I think that has also helped that relationship from the get-go. I'll just use gram-negative bacteremia as an example. We do a lot of work in that area. We use Phil Murray's BCID. And one of the things that we try to teach this approach is using our own local data to demonstrate to our clinicians that we're using local risk factors, local data to encourage de-escalation, even sometimes prior to susceptibilities returning. So in the example of, Enterobacter ACA, and I still get to use that because that shows up on BCID, I still get to use the old term, but Enterobacter ACA showing up, often anti-pseudomonal beta-lactams, plus or minus bank, were started initially in our critically ill patients. We then implement our stepwise de-escalation and typically are moving to a ceftriaxone, a 3rd generation cephalosporin at that point. We have developed ESBL prediction tools, and these utilize a number of risk factors. Very briefly, outpatient GI or GU procedure, exposure to a quinolone or beta-lactam in the last 90 days, or a previous history of colonization or infection with ESBL in the last year. In the absence of those risk factors, we're actually de-escalating at the time of BCID, even in these critically ill patients, because we do trust those results. If those risk factors are present, we've had to change a little bit in our approach, because the data that those are validated on and we published on, our ESBL prevalence was about 9% or so, and now we've doubled that. And so now we're in a 17, 18%, fast forwarding about 5 years later. So it's a little bit different now in those critically ill patients on how quickly we would do that. But the opposite is true. We may encourage escalation if the patient has a presence of those risk factors too, especially in the presence of a higher ESBL prevalence. The last thing I'll comment on that we've integrated into our antibiotic guidebook is a stepwise de-escalation approach. We always talk about, if you start with a carbapenem, then your first de-escalation is still probably going to be broad. If you start with ceftriaxone, you may get down to a very narrow spectrum with your first de-escalation. So we encourage this idea of stepwise de-escalation. It may be a third gen cef first, then down to cefazolin, or maybe an oral transition if the patient is ready. And so we encourage that approach based on the release of BCID and then the subsequent release of susceptibilities, where they're able to really narrow that down. But don't feel the need to wait 3 or 4 days for susceptibilities to come back in most patients.
Brendan, in your experience, as you're integrating this into your hospital, do you find that over time that you actually need to make fewer phone calls because they start learning how to do this without stewardship calling them? Or do you still find they pretty much need your guidance in de-escalating?
That's a good question. Most of the time we see the trend towards, once we implement a new targeted intervention, for example, as time elapses, our clinical pharmacists are excellent as steward extenders, and our physicians, they start to understand the routine and the knowledge of what the recommended approach is. And so certainly, yes, we see that. I'm sure others see that at their institution as well, which is very helpful because then it allows us to tackle a new intervention that may need more time and energy, at least at the get-go. But something that Robin said really struck me is, as the reports are nuanced or technology changes, it does need a reinvestment sometimes. We often need a reinvestment in the summer too, because of new residents coming on board. And so there are times and seasons, if you will, of that reinvestment.
Yeah, I know, just as we were one of the early adopters of a rapid diagnostic test for staph bacteremia, there was nothing more rewarding than when you went to call them and they're like, wait, I already made the change. I knew you were going to call. And it's like, oh my gosh, they're learning. But of course, July 1, you start all over and you just take baby steps again. But, as we started out with just a handful of rapid diagnostic tests, and now the challenge is there's so many, you end up, if you're making interventions on all of them, it becomes a full-time stewardship job of just doing that. And so, Katherine, I want to ask you, facilitating the education of healthcare providers. I mean, that's, again, a huge role we have, working with our microbiologist and bringing the instrument to life, basically helping the clinicians understand the results and trying to make that clinical decisions. And I think one area that's, we used to just get the organism identified, but now, we really can get the presence of resistance markers, which to me is not micro 101, it's micro 505. It's a much higher level of knowledge. And so how do you provide education to your healthcare providers with these tests that do provide resistance markers? What's your strategy?
So it really starts with the inception of the test implementation. So when we're bringing one of these tests on board, we want to actually have a feel for how often you're going to see results that, are going to be something weird or different, or something that our house staff isn't used to seeing. And then once we've established, how often we can expect this, then we really try to engage with the places that it's either concentrated, or with the frontline workers, or with the frontline house staff that will either need to trigger a consult to ID, or will trigger a consult to one of the stewardship team members. So depending on really what we're dealing with, and I'll use gram-negative resistance markers as an example. Typically once we start to see these positive gram-negative markers, that typically means that we need an ID consult. And so within the EMR, we work with our IT group to mock up several different options as to what will be the easiest and most appealing way to demonstrate to our clinicians that, this is the next step. And we really try to sell that across the institution. We, take it to all of the different section division meetings. We have a lot of buy-in from that perspective. Clinicians tend to react well to having options, right? So if they feel like they've been part of the decision, if they feel like, I want to see it like that, and that's how they get it, then they tend to pay attention more, and then they tend to tell you about it later, which is fantastic. I mean, that's always awesome when I have a clinician who says, "Hey, I saw that I had this CTXM, like, you know, you taught me about that." So that's always really rewarding. So, you know, we try to make sure that we're targeting the next steps to the right clinician. So if it's our ID physicians, you know, we're sending them towards the guidance that we've put together from the Antimicrobial Stewardship Committee, whether that's a chart that tries to make it easy, or try to at least, you know, designate certain antimicrobials with certain results. And then of course, with our frontline house staff, we try to make sure that we still provide them the ability to go in and learn about some of these other nuances, but we really want to make sure that they recognize that, you know, the next step should really be getting an infectious diseases consult, because those medications that they're going to require really are restricted to those service lines and things like that.
Right.
We also do a great deal of posting on the internet, on our app. We've integrated our guidebook with Sanford Guide, which has been really nice, because Sanford Guide tends to have this, or it does have this wonderful reputation, and everybody knows it, and everybody trained with somebody who knew it, or, you know, learned how to use it. And so if you're like, well, you know, just open up your Sanford app and then you click on that, you know, resistance marker, and now you have your local data. That's been really, really useful, and our physicians really like that. Otherwise, you know, we also try to make sure that we close the loop with our clinicians. So once we've rolled something out and, you know, they've seen what these resistance markers look like, then we come back, you know, several months later and show them, hey, here are some patients where it actually made a difference.
Oh, wow.
So this is, you know, here are some patient cases where, you know, because we were able to identify this resistance marker, we were able to change treatment, you know, this much sooner. And it's a great exercise for our stewardship pharmacists, and it's a really great learning opportunity for our physicians as well. So I really, really want to harp on that, because I think it's so important to close the loop on that education. Because if you just, you know, Brandon kind of mentioned, if you forget about it and then, you know, you don't really talk about it again until July, when you have this new batch of physicians, they don't know what you've done. They don't know what you're talking about. So really, if you can bring it around and show the staff what difference it actually made on a patient level, I think that really sticks with them, and it's really beneficial.
I think that's great. And I love the idea how you integrated the Sanford Guide with your own app. That's really brilliant. Ferric, you're in a large place. Any other tips you can give in terms of providing education for all these resistance markers that the microlab puts out, and trying to teach people what they mean? And, you know, it's complicated.
I think one of the challenges that I think Brandon alluded to is that it's not a static situation. Technology is changing. The prevalence of different resistant organisms is constantly changing. And so we want to have a system in place where there's this constant refresh and revision of the way we're thinking about problems. And we find that our trainees are really a critical link in this. They're not just there to learn, but they take the knowledge that they've recently gained and they really spread it around, because they're the first line that gets called. Our pharmacy trainees, our clinical microbiology fellows, our infectious disease fellows. So we, you know, have in-person plate rounds regularly, and we have a lot of sessions that are throughout the year where we're constantly talking about challenging cases and resistance problems. So these emerging problems and problems in our own hospital that are dynamic, we're having the same kind of experience with ESBLs, where for a long time, you know, they were a little bit exotic for us, but now it's extremely common because CTXM has been so successful disseminating through some of the more virulent enterobacterales. And so we're seeing a rise like the whole country is seeing. And a lot of it is in the community, which makes it doubly challenging, because you can have prediction tools, but if people are picking this up before they've even encountered the healthcare system, it's really hard to know when that next urinary tract infection is going to turn out to be more complicated.
Mm-hmm.
So we want to have this constant dialogue that involves the laboratory and pharmacy and infectious diseases and the other clinicians in the hospital. And the best way we have to do that, I think, is to make sure that our trainees are really quickly up to speed with all of this, because they're constantly in conversations with different parties about these topics. And they do such a tremendous job, I think, of educating all the people in the hospital. They think that they're being educated, but we should really also be, I think, recognizing the critical role that all the trainees are playing in terms of spreading the knowledge around. And that's how I think it kind of works with our hospital.
Thank you. Robin, I want to turn to you now. One of the areas that I think is really challenging, I practice in a large teaching hospital, and we have a freestanding oncology center. So we have a lot of immunocompromised patients, and you can't get the result fast enough for an immunocompromised patient. They're so compromised that literally every hour does count, just like sepsis patients. So what experience have you had in terms of focusing specifically on that patient population? What type of rapid diagnostic test do you recommend? Is there anything, unique that you feel brings more benefit to that patient population? Just kind of share what your experience has been or recommendations.
Yeah, great question. I mean, first of all, immunocompromised is a lot of different things, right? But we recognize that this type of patient population can go downhill very quickly. They're often very ill. And the differential diagnosis from a microbial standpoint can be extremely broad and needs to be acted on very quickly in order to idealize outcomes. Empiric therapy is often not enough because one needs to know exactly what's going on to pick the right therapy. Otherwise, you're on a multi-drug regimen and you don't know what you're treating, and you may actually not be treating what's there on top of it. So, certainly a rapid and I would say aggressive diagnostic approach makes sense in immunocompromised patients. And now with a lot of the rapid diagnostics that we have, we can really get to that answer for immunocompromised patients a lot quicker than we could in the past, and oftentimes without having to have them go through invasive procedures. But as far as diagnostics, I'm not sure that we have a one-size-fits-all menu. And I see a question kind of in the chat about, what should the lab offer, what portfolio of tests. I don't think we really have that. I think that you'll need to look at your own local immunocompromised host population and decide what answer you need quickly or what answers you need quickly. And then I think it's important for clinicians, pharmacists to work with their laboratory to say, for this patient population, it would be really helpful if I had a very fast test on respiratory secretions for X, Y, and Z, or a very fast test on CSF for A, B, and C, and so forth. And what can we operationalize to make that possible? Because in the lab, as Brandon pointed out, we're dealing with emerging technologies. We have lots of choices that we can make in terms of what we bring on and offer, and also how we prioritize them to get done rapidly. Some of the rapid diagnostics we have today, as you know, can be done in 15 minutes or an hour, and you get 30 plus different analytes on that same report. And like our lab is open 24/7, so there's no end to what's possible. But we do need to prioritize in the lab what gets tested first. So if I have 20 specimens in queue for rapid testing, is there a prioritization scheme in terms of what kind of patient moves up to get that test? So I think that the ways to operationalize that are first to figure out what you want. And that really depends on the patient and what's going to make the most difference to have quickly. is it a respiratory sample? Is it a stool sample? Is it CSF? You know, what exactly is it that would really help in the practice? But then to work with the lab so that, you know, maybe it's a restricted ordering situation where you can only order a certain test on an immunocompromised patient, then the lab knows exactly that that's, you know, a priority specimen. It comes in, it gets run right away. Or maybe somehow it gets marked as, you know, a priority specimen. The problem with that, by the way, is when you offer a route for faster testing for certain types of patients, somehow everybody's patient is that special type of patient. So you have to be really careful with that because, you know, that can be hard to operationalize. But still, some sort of working with the lab to say, this is what's needed. And I'd like to work out a system where this particular test on this kind of patient, when ordered, can get done and reported, you know, right away. I think we have almost infinite options today for rapid diagnostics, and they're growing day by day. So this is a very important conversation to have with your lab. But it might not just be your immunocompromised patients, you know, who need priority. You might have people coming into your emergency departments where decisions need to be made rather quickly, and we have the tools that can enable that, and they might be a priority too, even if they're not critically ill, because it's really informing a rapid decision that now can be made, and they don't need to sit around or be admitted to wait for those tests to come back. So I think the answer to your question is work with your laboratory, see what they can possibly offer. It's not that you have to become an expert in all the possibilities in rapid diagnostics, but if you see something you think could be helpful and your lab's not offering, or somehow the turnaround time doesn't seem to be what you're hearing about from other places, have that conversation with the lab and figure out what's possible. Not everything can be a priority. The lab just can't work that way, but a lot of things can.
Great, such great tips. And, you know, I agree. There's so many options now that you really have to focus on where can you make the biggest impact. You know, maybe it is in the emergency department with a viral panel and getting them to not starting antibiotics because it is a viral infection. I think you have to focus on one thing, especially for newer programs that are getting started, or you know, just trying to learn how to work with the microbiology lab. Focus on one thing and do it outstanding. You know, don't spread your efforts across, you know, 5 different tests, and you feel like you're spinning your wheels and you can't really show a difference because you're spread way too thin. And I think that's really one of the biggest challenges, because we do have so many tests available now. And one thing I learned very early on is, you know, walk down to your microbiology lab, because I found some of the things I wanted. They're like, Debbie, that's the size of a microwave. Where are we going to put it? There's no more space in this lab. Like, put it on the floor. You know, a multi-toff was like the size of a refrigerator. You know, so if you aren't a microbiologist, I would encourage you to physically go to your microbiology lab to see their workspace, because I learned as I wanted all these tools, you know, that was one, just physical space was a barrier. And then you really had to prioritize, well, how are we going to implement this? And so, Robin, I think in the immunocompromised patients, yes, they want everything rapid and fast, but you really have to look at which test is going to be the best match for that population. And it may not be the population you start with. It might be the emergency room, or focusing on just gram negatives and doing that really well. So I think all of us have practiced long enough to kind of have a strategy of where you put your effort. So I'm going to circle back before we move to our next topic. Brendan, there's been a couple questions just asking for you to briefly explain a little bit on your ESBL protocol. If you could just describe that in a couple more sentences about kind of the prediction tool, what that is, and how you actually use it.
Sure. And what we can do is I'll also type it in the chat, like the PubMed ID, to save a little bit of time there. But we have a gram-negative bloodstream infection database, and it allows us to create a number of local protocols based on those data that, in the absence of certain technology or in the absence of of other things available, they can be somewhat of a surrogate. It's one piece of data, to be clear. It's not the only piece of data, it's one piece of data. But this ESBL prediction score, so we assigned based on, it was a large sample over about 5 years. We have 200 to 300 isolates a year. So we had a significant number here. Looking at during the prevalence of about 7 to 10%, we were able to identify a number of risk factors. And so what we encourage and teach, kind of what Katherine was talking about as part of our education, is that everyone learns this ESBL prediction tool. So one thing that has really taught is you've got to get a good antibiotic history on your patients. And so that's one thing that we think is very simple for an accepting clinician to do is, okay, that is a critical question to get to. So part of the prediction tool looks at several risk factors. One, again, is outpatient GI or GU procedures. That was a predictor in our model if it was done within 30 days. One was the exposure to either quinolones or beta-lactams in a 90-day period. And probably the strongest predictor, which shouldn't be a surprise, is a prior history within the last year of an ESBL infection or colonization. And we then have in our teaching algorithm, it's graphical. And so based on the points that are scored, it will then tell you what the likelihood is of that patient having an ESBL. And so in the absence of all those risk factors, it's about 1%. They have a 1% likelihood. When you get up to 4 points, which you would get to 4 points in this if you had a history of ESBL, you're about a 45% risk. And so that's how we would apply that tool. And so it could allow for escalation. We may have a patient on piptazo or ceftriaxone, and if they score high enough, we may call and escalate, or even our steward extenders may escalate. And again, as I alluded to, now that our prevalence of ESBL is much higher, we probably have a lower threshold of escalating to a carbapenem, for example, and then able to de-escalate from there. But and that's how we apply it, both on the escalation side and the ability to de-escalate. And it works both ways. It really does, because we have really been a good carbapenem sparing facility for quite a while, just as part of our culture. So, but I'll type the PubMed ID in there so people can download that.
That'd be great. Thank you. All right, so let's turn our discussion now to a different topic of C. diff. Something that is really a challenge in stewardship programs. A lot of effort has been put into trying to decrease C. diff. But I think one of the first things is just making the diagnosis. Ferric, I want to ask you, there's been a lot of changes and recommendations of how to identify C. diff. Is your lab, are you recommending to do the presence of toxin first, or what's kind of your workflow to help the stewardship program diagnose C. diff?
Our laboratory only offers nucleic acid amplification testing. We have a standalone test, and we have it as part of a panel where there's a broader differential diagnosis. I think it's a perfectly reasonable approach to use one of the other multi-step algorithms, but there are trade-offs with both kinds of approaches. It really is more straightforward than it seems. It's very controversial because there's not a single right answer. Mm-hmm. And people try to balance the desire to get an accurate diagnosis and not overdiagnose or not underdiagnose. And whether or not you're primarily concerned with over or underdiagnosis will affect how you approach it. But any of these diagnostic tests, even a toxin assay, all they tell you is you have a toxin producing C. difficile. A lot of people think if you have toxin detected, it means that you have C. difficile infection, and that's actually not true. It's been amply shown that you can have free toxin detected and be an asymptomatic carrier. At the same time, you can have no free toxin detected, and you can have significant, even life-threatening CDI if you have the organism present. And so what you have to keep in mind is that there are limits to diagnostic testing. And the test is telling you what you think it's telling you. If you use a toxin assay, it's telling you that there are enough organisms making toxin to a sufficient degree that you can find them. So they correlate with higher organism burdens, but they don't, a negative toxin assay does not rule out the possibility of CDI. And then the molecular test is going to tell you the organism is there, but it's not going to tell you it's producing disease. And so, it seems surprising to some people that you still need a doctor in this day and age. You can't just practice medicine with a laboratory. And somebody has to actually go and evaluate the patient. And the more ill they are, the more potential problems they're going to have from having undiagnosed CDI. And so really the key here is not so much what test you use, but how you decide who gets tested. And there it's, I think, really essential from a stewardship point of view to have institutional criteria that everybody is familiar with about the clinical signs and symptoms of CDI. And some things that are in the literature turn out not to be robust. A recent study that came from Dustin Bosch and Alex Greninger at my institution looked at thousands of patients who had isolated leukocytosis. And this is one of the most common indications for C. difficile testing at my institution, where people say, I'm taking care of this patient and he doesn't have any diarrhea. I'd like to order a C. difficile test because I've read that isolated leukocytosis can be a sign of CDI. And so we found that our residents were every week multiply getting called about this problem, and they were asked to approve C. difficile testing. So Alex and Dustin looked at all of the white counts from these patients and looked at patients who had nucleic acid testing positive for C. difficile and found there was really a very poor correlation. And they divided things up between outpatients, emergency room patients, inpatients. And most of the calls were coming from inpatients, and there was virtually no correlation. I mean, you could occasionally find a case, but when you looked at all the people with high white counts, you know, it really wasn't a standalone reason to get C. difficile testing. So I thought they did us a big favor, because looking at these data, our residents realized this is not really sound thinking. You're going to end up actually probably overdiagnosing C. difficile because you have a really flimsy evidence base on which to order the testing. On the other hand, we see many patients where they have signs and symptoms of C. difficile illness where the toxin testing is negative because the organism burden is fairly low. And if you were to rely only on toxin testing, you might delay the diagnosis of those patients, so they have to get sicker before they actually get recognized and treated. And that's a cost also. So I think people need to look at what they're willing to trade off, because no test is going to substitute for clinical judgment. And then you have to get the lab in sync with what your clinicians are using as criteria for testing. And that will make sure that the test that you get is most likely to reflect true illness and not colonization. So I think it's yet another one of those situations where all of us who have different opinions, we kind of agree about the basic facts, but we're differing in terms of what trade-offs we're willing to make. I worry very much about underdiagnosis of C. difficile, because I've seen patients develop extremely severe illness from a late diagnosis. But it's also clear that overdiagnosing it is costly, that giving patients antibiotics they don't need are only going to have a downside, not a benefit. And so this is this tightrope that we have to walk, and realize that no matter what we do, we're in the end having to make a clinical assessment and decide whether or not the patient has illness which is sufficiently severe that you would treat it.
Mm-hmm.
Because if, you know, some patients may have C. difficile, but it's so mild that simply letting tincture of thyme and not exposing them to high-risk antibiotics will result in resolution. And I think the people who are arguing for using less sensitive tests like toxin testing are arguing that we don't have to jump on every patient who has one loose stool, you know,
Mm-hmm.
that might have C. difficile, because that is probably unnecessary treatment that you're exposing them to.
Thank you for your explanation, really kind of weighing the pros and cons of both approaches. Robin, what is your strategy in your hospital? As he described, everybody kind of has a different take on this, and you've got to be able to sort of weigh the risk benefit of each approach. So what's your approach?
Yeah, I really liked the way Ferric presented that. We don't have a perfect test to tell someone that you have C. diff that needs to be treated, because there are some of us that can be carrying this organism. And so, you know, it depends on the background in which the test is implemented. Our story, back in 2006, we were developing a PCR assay to try to target hypertoxin producing C. diff. And we accidentally realized that the antigen test that we had been using for quite a long time had only about half the sensitivity of a PCR test for C. diff. So in July of 2007, this is 14 years ago, if I counted that right, we started using PCR for C. diff. And we still use the same assay because I have not been really convinced that there's something better to step over to. I wish there was. I wish we had an assay that was sensitive, specific, really told us that that patient had C. diff that you need to treat, but I just don't see it. And right now, I'm a big fan of rapid diagnostics. We can do that rapidly with PCR, and we know that that approach is sensitive. It's just that you have to use clinical evaluation of your patient to make sure you're appropriately testing. You can't be testing patients like Ferric talked about who maybe don't have a high pretest probability of even having C. diff disease that needs to be treated, because you're going to get false positives then. So to sum it up, we've been using PCR for 14 years, and I really would love to step to a better test, but I just have not found it.
So appreciate that. Marnie, I'm going to ask you to jump back on and further take some of the questions that we are getting from the audience.
Absolutely. Thank you, Debbie. And Debbie, are you you're going to step away now?
I am. Thank you so much for your time.
Yeah, I just wanted to make that notation and wanted to thank you so much for so eloquently moderating such a stimulating conversation. And I'm sure all of our
working with all of you.
I'm sure our participants would be applauding your efforts here. So thank you very much. Okay, so I'm going to take over moderating the session with our experts. So again, continue to send us your questions in through the question or chat box. So we'll get to those as we pass over the top of the hour. To finish up, before we head into objective 3, which is around sequencing, I just wanted to ask Brandon one quick question here around your guidelines for C. difficile testing at your institute. Is it similar or different than what Dr. Fang and Dr. Patel described?
We have a reverse algorithm. So we are PCR first, and PCR positive will then reflex to GDH and the toxin assay. And that's a new thing for us. We have been PCR for a long time, but we merged with another health system, and that was adopted through conversations between clinical microbiologists and our stewardship and ID team. We certainly weighed in. One comment real quickly on this whole idea of C. diff. I mean, this should be a very important metric for everyone, but it's also a shared metric. So your hospital is very invested in this. You know, infection control is very invested, quality is very invested, stewardship is invested, and they're all interplay. You know, you could be an incredible steward, but if you don't have hand hygiene, then it doesn't matter, and vice versa. So this is such an important metric for us. Our issue really was, if you want to say issue, when we introduced our multiplex GI panel test, we did not do a good job as a stewardship team to have working with our clinical micro lab to put in great guidance. And so that in its early infancy for the first maybe 12 to 24 months was greatly overused. And when we look back at that, we had about 60% use that we deemed as inappropriate. And so now we have reeled that in over the last couple of years and certainly feel much better about that. But that's part of the idea is you don't want to just throw a rapid diagnostic out there without the guidance, because it doesn't matter how established your stewardship team is or how new it is, there still can be inappropriate use of a test without guidance or guardrails in place for the ordering.
I think one of the things, if I could comment on what you're saying, Brandon, that makes this a very difficult decision is the fact that hospitals are rated according to their CDI rates. And this is often laboratory-based surveillance. And the problem is that the corrections that these systems try to use in order to adjust for the diagnostic testing that's being done are really not very sophisticated. And so hospitals may get penalized for using highly sensitive tests if many of the cases they're detecting are actually colonization. One of the reasons hospitals are going to these complex combinations of tests, which frankly for a clinician can be confusing, because if you find out that the patient is PCR positive, GDH positive, toxin negative, it generates a lot of questions, and a lot of the answers really depend on that individual case. But I think that the current algorithms for counting cases do not penalize hospitals in that way. If the final test is a toxin test, then that's the result that counts, and yet the clinician still gets the information that toxigenic C. diff is there, and if there's a high pretest probability, they might be able to fudge that. So it's kind of a way, I wouldn't say I don't mean anything pejorative that it's gaming the system. It's creating a system that tries to minimize the unfair penalty to a hospital for having a highly sensitive diagnostic. But what we really need is the recognition that laboratory-based counting of CDI cases is really not very accurate because of this problem distinguishing colonization and disease. And we need a more sophisticated tool, I think, for measuring how much CDI is in a hospital. It's a legitimate thing to measure, but the way it's being measured is so simplistic, it's not really very accurate. And that's causing laboratories and hospitals to worry about the consequences of their test choice and how that will potentially penalize them.
Yeah, we had that exact conversation when we rolled this out, and I saw a comment in there. Hello, John Williamson. That was my residency program director at Wake Forest. So, but we had that exact conversation on what to release or not. And right now we have fallen on we release everything, and it becomes a conversation with the provider and the primary team, either from stewardship or just among themselves, on how we interpret those when they're discordant, as you mentioned. That's probably the most complicated one is PCR, GDH positive, and then toxin negative. So certainly that's a great point. I'm glad you brought that up.
All right, I got to switch topic to objective 3. I'd love to hear more about this because this is so informative, and I think it's where you're talking about putting this stewardship and diagnostic into action and hearing from you about your approach and where the challenges are. So objective 3 is now moving into incorporating some new technologies, next-gen sequencing into your clinical decision-making. And Dr. Patel, I want to hear from you first is the question being, are you using this type of technology, next-gen sequencing, in your clinical practice currently?
Thanks, Marnie. Yeah, absolutely, we are. This is a growing field. I spend a lot of my time looking at next-gen sequencing data from the clinical lab. We're using it for sequencing isolates for clonality testing, so comparing genomes to see if they're related and there might be evidence of nosocomial transmission. We're using it to look for resistance in organisms like Mycobacterium tuberculosis and cytomegalovirus. And we're also using it for more of a metagenomic approach where we're taking, for example, the 16S ribosomal RNA gene, amplifying it and sequencing it using either Sanger sequencing or next generation sequencing, depending on the specifics of what we're seeing. And there will be many more applications to come as time goes on.
I'm going to come back to you about some of your approaches on that and the impact of this in the practice. Dr. Perez, are you using this type of technology in the clinical practice, and how do you use it?
So our laboratory has invested a lot of time and resources on next-gen sequencing, and we certainly have a whole lot going on in that area. But really, I think we're not using it to make on-demand decisions. We're really using it, as Dr. Patel mentioned, from an epidemiologic standpoint to look back and see whether or not there's evidence of an outbreak or nosocomial transmission. Also to look back and see what the populations have looked like across our health system, because we are a centralized laboratory, and we have hospitals throughout the greater Houston area. So sometimes it can be very beneficial to kind of know exactly what's happening in, the south side and the north side, and trying to kind of put together that puzzle. But in terms of actually using it on a day-to-day basis, that really hasn't come to fruition just yet. We do have the ability to order sequencing on isolates, and that's done sometimes for very specific patients and very specific instances. But to say that it was directly going to affect the patient's treatment, that we're really not there yet. But it does help us inform, more background on that patient specifically, or kind of it helps us have a grasp as to what we're really kind of dealing with or what's to come.
Thank you. Dr. Fang, I know we talked a little bit about this in the first webinar.
I think this is something that is extremely, maybe dangerously appealing to clinicians, that they can have one test to rule them all, and they can order metagenomics and know everything that's in a sample, and not have to rely on culture-based diagnostics or individual tests for specific pathogens. And there's a risk that I think the tests used in a indiscriminate way could really be antithetical to the goals of stewardship. That we have the technology, in theory, to detect all the microbial nucleic acid that's in a sample with tremendous sensitivity. But this is very likely to be hard to interpret for most samples that are from non-sterile sites, and may lead to overtreatment. And I think right now, the situation we face is we have a lot of clinician requests for things like plasma cell-free DNA testing at Carius, which is obviously very powerful technology. In our experience, which mirrors that of recently published from Stanford, from a very nice paper from Niaz Benet and his colleagues, the yield is actually pretty low. That sometimes we find corroboration with conventional diagnostics a few times, but probably on the order of 5% of the time, we get a result which is new and changes therapy for the better. And occasionally, like the Stanford group, we're finding results which are actually misleading and in retrospect led to unnecessary therapy that's potentially harmful. So I think with the metagenomic side, it's really a work in progress. We're still trying to figure out those patients where it's most likely to be beneficial. It's used a lot for fastidious pathogens. So in patients who have culture negative endocarditis, where the usual suspects don't turn out to be forthcoming, then a lot of times it's the last resort test. But what we're trying to resist is the idea that every patient with a negative culture has to end with an expensive metagenomic hunt before they accept the fact that it's a culture negative inflammatory situation, because that would be very expensive. We've also occasionally had utility where we were looking with single simple 16S amplification, and we had multiple bands present, and so we can reflex those to metagenomics. And we had a patient with a mycetoma where we were getting all of this superficial colonizing flora, and by using metagenomics, we were able to find the actinomedura at the heart of that as a minority population to clinch the diagnosis of the type of actinomycotic mycetoma that the patient had. So there are these special situations with fastidious pathogens and polymicrobial infections. I know that Robin's group did a beautiful study with prosthesis infections, where a lot of times the organism burden is very modest, and metagenomics can potentially be more sensitive and also identify polymicrobial infections and fastidious pathogens. And so I'm kind of seeing the horizons be that we can identify specific situations where metagenomic next generation sequencing is really profitable and leads to useful clinical results. But I see a danger in applying it to everything, because it's so sensitive, it will generate a huge number of results, most of which are not really clinically relevant and may be promoting unnecessary use of antibiotics. So that's kind of where we are with this right now.
Thank you, Dr. Fang. That's a great segue. And Brandon, I'm going to come to you about interpretation of data, but Robin, I wanted you to share with you how you've used it. You know, have you used it in an impact study to show where the value lies to enhance quality or enhance, you know, optimizing therapy? You know, maybe an example as Ferric mentioned.
Absolutely. I think this is an open field right now. We've done a number of studies. So on the side of bacterial whole genome sequencing from isolates, we've used that technology to investigate a number of situations, outbreaks of resistant and susceptible organisms to address clonal spread in various different hospital settings, including our own. And I think it's really helpful. I mean, I think whole genome sequencing of bacteria is the standard today for clonality testing. And there are lots of things going on in your hospitals that you don't know. And there's sometimes when you think you have a problem and you don't. And this is a type of test that can answer it. But I'll leave that because I don't think it's completely germane to the conversation here. It's more of an infection prevention and control type of test. On the individual patient level testing, absolutely. So we use 16S ribosomal RNA gene PCR and sequencing routinely in our clinical practice. We have a paper that is in press in Clinical Infectious Diseases where we did a retrospective look back on testing on 460 patients over the past 2 years. And we got positive results in 17% of these patients using the 16S approach, 20% using cultures. So that's interesting, right? So you get that sort of compare of cultures versus molecular diagnostics. And 90% of the positive results that we generated using sequencing were associated with clinical infection. So I think the specificity is very important and it was very good. But also important was to look at where it made a difference. In my mind, we're looking at a lot of different disease processes all at the same time, and we have to tease this out on a patient level basis. And to give you an example there, to me, the most useful clinical indication is in blood culture negative endocarditis, when you have a heart valve and you don't know what the organism is. It's clear, the literature is clear that in that case, this kind of approach is very useful, performed on those heart valves. And our study recapitulated that those were the specimens that were most likely to have positive results with a 12-fold increase odds of positivity compared to anything else. But we need to do that kind of study for every scenario, for CNS infections, for bone and joint infections, and even for subsets of different clinical presentations and patient types within those different sort of specimen types, if you will, for those of us in the laboratory. This is a very much open field. We also, like Ferric mentioned, looked at our send-out testing for shotgun metagenomic testing, but this time on spinal fluid to UCSF. And the return rate was very low, like Ferric mentioned, for the plasma testing. But sometimes you get surprises. So we published our experience in Journal of Clinical Microbiology last year, and most of the tests were negative. Most of the testing was what I would call comfort testing, which Ferric mentioned, people with an obvious inflammatory disorder, but they wanted to know for sure that they weren't missing anything. So they'd send off the CSF and they feel comforted by the negative result, I will say. And that's interesting. We have to think about what the value of that is. But a lot of that was this kind of testing. But there was also a lady who ended up passing away in whom a Bunya virus was detected. And just a month ago, the CDC completed their workup and found Cache Valley virus in that woman. So, you know, we will also be able to find things that we don't have other diagnostics for, and we wouldn't have known without using that kind of testing. And we have to figure out then when is the right time to move to this kind of testing. It's expensive. Some of it's really very expensive, some of it not so much. It's not necessarily fast, and sometimes the results are confusing. Many times they're negative. So we really have to define the patient populations who would best benefit from that kind of testing.
Thank you. And thank you for summarizing some of your studies as well. I think that's so helpful, and hopefully people that are listening will refer. A PubMed search on Robin Patel will bring up a lot of those articles as well. Brandon, we've got a few minutes left. And turning to you, in webinar 2, you talked a little bit about next-gen sequencing and the things that you were doing. So maybe just mention what you're doing, but I really want to focus on how do you as a steward interpret the data?
That's a good question. I'll be very brief so we don't run out of time here. We're primarily using it in clinical decision making, and our, I would say our go-to, if you will, is cell-free DNA testing with Carrius. And this we have a paper that's currently in submission, so I'll give you some generalities here. But we the way we integrate it, it's not protocoled, and it is really a restricted test to an ID consult, and I really think it should be at that point. We use it in both pediatrics and adults. And we have not had the same really low yield. We use it very selectively in our patients. We are using in some of the cases that have been alluded to, culture negative endocarditis, but we also are using it in patients who have been on antibiotics for a prolonged period of time that we feel are not allowing for some of our traditional methods of identifying pathogens. But what a lot of folks have said, one thing that we've noticed is, interpreting, is it an organism detected or is it truly a pathogen? And I think the jury's still out on that for sure. And it becomes confusing. And that's why I think you have to have ID consult expertise on board for applying the information for sure. One thing we certainly have had great anecdotal experience, and so sometimes those are very powerful where they have found things that otherwise would not, and we've seen a tremendous clinical benefit. We even had a Legionella case somewhat recently that was detected, and we're able to streamline therapy and dramatic turnaround in a patient who was doing very poor in our ICU. So there are cases where those happen. I would tell you, you can consult the medical director of these places. You also have to remember that, for example, for Carrius, they have thresholds at which they report organisms. And so if you truly have a pretest probability that you say, this person looks like they may have rat bite fever, for example, and we don't see the result there and that we're looking for, you can call and they can actually release that information to you of organisms that fell below the threshold, and it may still match your differential for the patient. And so we have had success with following up with the medical directors of these labs, even outside of our own institutions. And so I would encourage you to do that. And we have seen that as actually an added benefit for the clinical utility of ordering some of these tests.
Thank you, Brandon. That's a nice final addition to this conversation on the topic. So more to come on that topic as well. And I think just helping people to understand and outline where's the utility right now and when not to use it. The attendance code is now posted both in the chat box and on your screen. I'll read it to you. RDP, all in capital letters, 4, and then capital A, capital X. There you can go. You need that to claim your CE after you take your post-test and evaluation. With that, I want to thank our speakers. We're out of time. It's been a terrific discussion. Both webinar 1 and 2, as this was a part of a series, your webinars themselves. So I encourage our participants, if you missed it, go back and watch them. They're on the CIDRAP ASP website. And then, of course, this session itself has been recorded, so you can view it or share it with all of your colleagues. So thank you, Dr. Patel, Dr. Fang, Dr. Perez, and Dr. Bookstaver for 2 sessions really with us and coming together. And then also thanking our partner, Society of Infectious Diseases pharmacists, specifically Vasilios Athens and Bruce Jones for their support and expertise in the creation of this, and ProCE for their support as well with the continuing education. And finally, our educational grant from bioMerieux. Thank you, and hope you all have a good afternoon and good evening.
It's been a great pleasure.